One of the things that I think is really important is also sustained MRD. So, whether we're talking myeloma or we're talking DLBCL, I think it's really sometimes in patients it's easy to achieve MRD, but can you sustain it? And so I think that that's going to be a big endpoint moving forward, that it's not just MRD, but sustained MRD.
I'll agree with Suzanne that MRD is maybe got a more promising future in DLBCL than it has in past. The tests we've usually used, like clonoSEQ from adaptive, very powerful for CLL, powerful for mantle cell lymphoma, but not super powerful so far for DLBCL. And we have some promise. This new company, Foresight Diagnostics, led by Asher Lizaday and some of his brilliant colleagues, might be more sensitive for detecting DLBCL, MRD. And we even have, proposed trials like this Alpha-3 trial of getting R-CHOP complete remissions using these fancier MRD tests like the Foresight test to pick up the MRD positives and then giving the therapy to the positive patients. And Alpha-3 is designed as a randomized trial, take those MRD positive patients and randomize them to, in this case, allogeneic CD19 CAR T. Whether that's a perfect trial, has some shortcomings, we could discuss it, but at least it's going to be a real actionable utilization of a new type of MRD assessment for DLBCL specifically. So I do think that's super cool. Yeah, maybe MRD has a real role in the future of DLBCL if we get good tests.
You said it was Foresight.
Yeah, Foresight Diagnostics, and the name of the test, instead of calling it clonoSEQ, I forgot the brand name of the test now. But yeah, for the Alpha-3 trial, which is not open yet, I don't think.
And anybody wants to make any comments on the whole concept of compartment problems that we have with MRD testing, which has even been a problem in myeloma, where I think MRD is most advanced. If you look at the recent FDA approval of MRD status as a way of evaluating patients for long-term outcomes, it has to be patients who are in complete remissions. And so there are some reports of patients, quote unquote, who have detectable disease in the lymph nodes, yet they are called MRD negative. And, how do you guys square those concerns?
I think in the case of DLBCL, since it's not a marrow disease per se, we're not going to have a gold standard above blood. For myeloma, for CLL, maybe for mantle cell lymphoma, marrow is going to be the juicier site. And it always has been when we have head-to-head studies. Whether it matters if it's juicier, that would depend on the test. But DLBCL is not by definition a marrow disease. Some people have a lot of marrow involvement, a lot of them don't, or not detectably. So I think it's going to be a blood-based assay for DLBCL. And honestly, that'll help to unify it with all the rest of oncology, where all of our lung cancer patients are getting ctDNA tests blood-based, and therefore the technology platforms are all looking to be blood-based platforms. I think in DLBCL, blood-based will have to be the gold standard, probably.